Hi y'all, this is me. It came to my attention this morning slash late last night that one of the lectures that was recorded from session A cut off in the middle of the emerging disease slide, and so nobody got to hear the end of it from either group. So that being said, I figured I'd make you a quick video to allow you to be able to see that. So I thought that I would start with the Arbovirus slide and then give you the emerging disease slide. And while I'm at it, since I'm making a video, I thought that I would then go through the vignettes quickly with you. Alright, so here we go. Just as a refresher, arboviruses is a shorthand quick term for arthropod-borne viruses, so that's anything that's transmitted by an arthropod, namely in the case of infectious diseases, we're talking about a tick or a mosquito. Sorry about that. Once again, I grouped these guys and flagged them by what they have in common as opposed to what each of these viruses have that's distinct about it, which is a little bit the inverse of the way that we'd been doing things previously. These guys are quite diverse genetically, and there aren't a lot of commonalities that you could say across the board, so we put everything together in these odd little flags, because if you flagged everything distinctive about each one, it would be quite extensive. Okay, so the diseases we're talking about here are dengue fever / dengue hemorrhagic fever, two diseases caused by the same virus. It's abbreviated on this slide as DEN. Eastern equine encephalitis, or triple E, tick-borne encephalitis, or TBEV, West Nile fever / West Nile encephalitis, which is abbreviated WNV. We already talked about West Nile encephalitis, but here we'll talk a little bit about just standard West Nile fever. Yellow fever, chikungunya, which is abbreviated CHIK, Powassan fever, or POWV, and Rift Valley fever. Alright, so the things that all of these guys have in common, again, is that they're spread by arthropods. So we have the mosquito group over here. Sorry. New screencast app, still getting used to it, sorry. The mosquito group over here, and the tick group over here. So for our mosquito spread viruses, we're talking about West Nile, triple E, dengue, chikungunya, yellow fever, and Zika virus. And for our tick-borne viruses, we're talking about Powassan and tick-borne encephalitis virus. One thing I pointed out in the A group, but we didn't quite get to this slide with the B group, was that saying mosquito, and saying tick to a lesser extent, but saying mosquito especially, is really like saying bird. Okay, that you have eagles, you have hummingbirds, and you have a whole wide variety of stuff in between. So mosquitoes are equally diverse. The reason this applies to infectious disease is that not all mosquitoes are capable of spreading all mosquito-borne viruses. This is particularly relevant when it comes to infectious disease geography, because if you have a case of a certain infection in a certain geographic area, and you don't have a vector that's capable of spreading that infection, you'll just have a single patient with a single case, and they're not at risk to spread it to anybody else. We've seen that especially in the news lately with this guy right here. So if anybody was local over last spring and this summer, one of the things you would have heard on the local news was, oh God, we have a Zika patient in Maine. What are we going to do? Well, absolutely nothing. You treat that patient, everybody's going to be fine, because we do not have the appropriate mosquitoes to spread that. The mosquitoes that we're principally going to talk about today are these guys right here, Aedes aegypti and Culex pipiens. There are more Aedes mosquitoes, there are more Culex mosquitoes, but these are the ones that we principally are interested about today. Aedes aegypti you find in the southeastern U.S., and really across the tropics all around the world, but you don't really find it north of there, nor do you really find it south of there. Sorry, south of the Tropic of Capricorn. I realized that didn't make any sense. So if this is a globe, here's the tropics. You don't really find Aedes mosquitoes down here. This is my sad version of South America, and the bottom part of Africa and Australia, which somehow has left the planet. I left my stylus at home, if that wasn't clear, and I'm drawing with my finger. And you don't really find it above either. However, you do find them in this nice belt in between. Culex pipiens you find all over the world. So anyway, a pathogen that's capable of spreading by Aedes aegypti, you're going to find restricted. Pathogens capable of being spread by Culex mosquitoes, you're going to find globally. All right, so our guys that are of interest to point this out are Zika, yellow fever, chikungunya, and dengue. These are only spread by Aedes mosquitoes. Tripoli and West Nile are Tripoli and West Nile are also spread by these, but they are also spread by Culex mosquitoes. So we have these guys here, West Nile and Tripoli. Up in the northeast, we do not have the others. For tick-borne arboviruses, we're principally speaking here about tick-borne encephalitis virus and Powassan virus. These guys are found fairly widespread geographically. We do have them in the northeast. We have them all over North America, South America, Europe, Asia. They're pretty widespread. Okay. So one other commonality that's important to point out are some clinical features. Neurotropism is a big one. Only some arthropod-borne viruses have neurological manifestations, others do not. So we talked already about West Nile having it. You can tell just from the names that T-Bev and Tripoli are going to have it because they have encephalitis in the name, right? If you've been following the news, you would know that Zika has some neurotropism, but specifically just for developing fetuses. You don't typically see neurological manifestations in adults, with the possible exception of a small number of Guillain-Barré syndrome patients, but it's not the typical manifestation. Powassan virus is also a tick-borne encephalitis. It is not the same virus as this guy right here, but it causes a very, very similar disease. Alright, and then finally the one to point out here is yellow fever virus. Principally speaking, yellow fever causes a different clinical manifestation. We'll get to that in a second, but it can also cause encephalitis as well. Alright, so arboviruses where travel history is important are these guys right here. Dengue, chikungunya, yellow fever, Rift Valley fever, and Zika, again, are all spread by Aedes mosquitoes, and so you'd have, in order to see a patient with those in the Northeast, your patient would have had to recently traveled to the tropics or slightly north or south thereof. The other one that we have on here is Tripoli, and the reason Tripoli is on here is that it's pretty tightly restricted to the east coast of the United States. So if you were a practitioner in Maine, you would not think of Tripoli as a travel-associated virus. However, if you were a practitioner in California, you would. You wouldn't see a Tripoli patient in California unless they had recently been traveling on the east coast of the United States. Alright, some of these have hemorrhagic fever manifestations, and those are dengue, Rift Valley fever, and yellow fever. This is not hemorrhagic fever in the terrifying horror movie Ebola sense, where you have this just overt hemorrhage coming out of the ears and eyes and nose and mouth. This is more of a subdermal hemorrhage, where you have leakage of the capillaries underneath the skin, and what that comes out looking like is another kind of rash, and this is called a petechial rash. Unfortunately, I don't have a picture of it, but basically, if you could imagine someone's arm, I can already tell this is a really bad idea to try to draw this, but if you could imagine somebody's arm, what you would see on it are these little teeny dots that look like somebody's bleeding underneath their skin. That's the kind of hemorrhagic fever that you see with these four. Okay. Speaking of which, another thing that that you see, and just if you're in the A group, I added this from last time because I realized I more or less neglected to mention it, and that is that for a couple of these guys you can see limb rashes. So I added dengue from the hemorrhagic fever form, but again you're going to see that as a petechial rash. But West Nile and Zika in particular, you can see a forearm and lower leg rash with these guys. You don't see it with everything, with every case of these, but you can see it, and this is a maculopapular rash. One of the other manifestations that you see that's very unique to dengue and chikungunya is severe pain. Both of these viruses, they present clinically as a patient that's got a mid to moderately high fever, and they don't feel well, they're exhausted, etc., etc. But with dengue and chikungunya, the really key tip-off, other than travel history, is that these patients have severe long bone pain. It's not really clear pathologically where that comes from, but it is extremely clinically unique to these two viruses. Oh, loud. Okay, so excuse the drawings. I just realized that none of what I did a minute ago recorded, so I'm going to do it again. So we're talking about emerging viral diseases. We're typically talking about viral hemorrhagic fevers, hantavirus pulmonary syndrome, or henipaviruses. So to go back to viral hemorrhagic fevers for a moment, and again here we're speaking about Ebola, Lassa, Marburg, Old World hantavirus. There are some others. Crimean Congo hemorrhagic fever would be one. But these are the ones that are most important to know, the ones that are listed up here. These hemorrhagic fevers, pathologically, they start in the very same way that dengue and Rift Valley fever did that we described a minute ago, but rather than ending with just mild capillary leakage and petechial hemorrhages, what you see is that you have this massive breakdown of the endothelium. So these viruses up here all replicate very quickly, and among their numerous target cells, they really like to bind onto and infect endothelial cells. So these are the cells that line the critical place where you find endothelial cells in this particular discussion is that you find them lining the walls of blood vessels, and if these become lytically infected and start lysing and dying, you have a real structural breakdown of blood vessels, and when that happens, you have blood leaking out into the tissues. And so it's not just mild capillary leakage, you have entire major vessels that start leaking. When that happens, you have a pouring of blood and lymph into body fluids that then starts exuding from different body cavities. What happens very quickly is that you have a massive volumetric shock and additional shock from very high fevers, and then you have rapid mortality events. One of the things that we learned in 2014 with Ebola is that if you give appropriate supportive care, including fever control and blood transfusions and fluid replacement, that you can actually cut the mortality rate down by quite a bit. But that supportive care is often not available to patients that wind up having these infections. The next one that I have listed on here is hantavirus pulmonary syndrome. And so this is a respiratory infection, but rather than thinking of it the way you'd think of a pneumonia, it's better to really envision a viral hemorrhagic fever. So rather than blood, you have a pouring of lymph fluid, but what you end up ultimately having is a massive infiltration of lymph fluid into the lungs. So rather than having lungs that are inflamed, which is pathologically what you see during pneumonias, you actually have lungs that are just filled with fluid, which is effectively like a person drowning in their own body fluids, which is every bit as horrible as it sounds. So hantavirus pulmonary syndrome has an extremely high mortality rate as well, as you can imagine. The reason I have this little mouse here is that hantavirus, it turns out, is a totally normal virus that is found in the GI tract of most rodents, and they virtually never have clinical signs from it. And so something that's extraordinarily harmless to rodents, so you have your mice, rats, squirrels, all that kind of thing, it ends up causing this quite high mortality rate event in humans. One of the issues that you see with rodents is that they shed hantavirus in fecal pellets, and when those get dried out and aerosolized, they can be inhaled and actually cause clinical signs in humans of hantavirus infection. What we describe here as old world hantavirus, the ones that cause hemorrhagic fever, we see that in the eastern hemisphere, and we also see it in the western hemisphere, but only west of the Mississippi River. Hantavirus strains that cause pulmonary syndrome, we see that all over the world. The last thing I have on here are henipaviruses, and so this is a very old and very confusing term, and it's a collective term for these two viruses right here, Nipah and Hendra. The only reason I put it up here, because it has no taxonomic validity to it, and it's describing two different syndromes and caused by two different viruses, is that you do still see it in the literature sometimes. It was previously thought of as one virus that was called by two different names by two different groups that had discovered it, but it turns out they are indeed two viruses. So if you see that, just know it refers to the combination of these two, either or. Okay, Nipah virus is typically found in pigs. Hendra virus is typically found in cattle. Sorry, horses. Those are not cattle. Those are horses. The people who are most at risk for contracting either Nipah or Hendra are people who have very, very close interactions with these animals. So these would be farmers or large animal veterinarians or jockeys or slaughterhouse workers, things like that. So it's not people who kind of wander by a pig at the state fair. That's not the kind of person who would contract Nipah or Hendra. In addition to that, there's geographic limitation on these guys in that Nipah is typically found in Southeast Asia, most notably Indonesia and Malaysia, and Hendra is also found in Southeast Asia, but in addition to that has spread quite nicely into Australia and has really gotten a foothold there. But we don't typically see either of these in the United States. Okay, so I put this here, and this here, and the same point I'm about to make also applies to Ebola, it also applies to Lassa fever, it also applies to I lost my train of thought, MERS and SARS as well, but the actual natural host for those viruses are bats. So given that so many emerging and zoonotic diseases have their origin with bats, it leads me to suspect that there's some common ligand that bats and humans share that's close enough that a lot of things can jump in between them. But if you have anybody who's had exposure to bats, that's something to really watch out for. Okay. And I realized I may have just said that in a confusing way. Hantavirus is not a natural pathogen of bats, it's a natural pathogen of rodents, but the other guys I mentioned, they all come from bats. That's, again, MERS, SARS, Nipah, Hendra, Ebola, Lassa, all those guys. Okay. So your flags to look for emerging diseases are somebody who's had recent exposure to animals, somebody who's traveled recently, somebody who has some funny illness that you can't explain, they drop dead, and then everybody in their house drops dead next to them. That's usually a tip-off that something's going on here. And then, of course, high mortality is another big clue. Okay, so that's the end of this. And what I'm going to do now is go through those vignettes really quickly. Okay, so I have 2 more vignettes that I want to go through. Several of you guys have written me asking if you got the correct answer, and most of you did, which is awesome, so good job. So the first case that we had today is a case of fever and cough, and just call attention to our location as usual. We're in York, Maine, and we're in the ER, and it's February 12th. And by the way, that is where I live, and that is down the street from my house, and this case is actually one of my girlfriends. But anyway, that's beside the point. So our patient is a female 37-year-old. She's a bartender at Ruby's Wood Grill, if anyone's in New York. Fine place to eat. She has complete childhood vaccination series, and her medical history includes appendectomy, well-controlled anxiety. She's treated with citalopram and lorazepam as needed. Her travel history includes recent visit to see her family in New Mexico. So nothing too exotic here, but she does have a little recent travel, and that's, something to consider, but there you have it. Okay, so her presentation at the ER, she comes in, she's had a dry cough for 3 days, she hasn't been eating, she's got a low-grade fever between these ranges, and she just feels terrible, and she feels like she's got something that's way worse than a cold. Oh. Okay, so what are some possibilities that she could have? You might want to pause the video at this moment, think about what some of the possibilities would be. Okay, now restarting. If you didn't pause right now and think. Okay, now we're restarting. How would you test for any of those possibilities? Okay. So, hopefully you would come to the conclusion that for some viruses that would cause presentations like this, there are rapid tests available, and specifically there's a rapid influenza test, and there's a rapid RSV test. Again, she's an adult, so this is not particularly likely, but this seems like a good possibility. And if you did her test and it came out looking like this, where she has a band appearing right here, you've just now had a positive influenza test. Okay, so how are we going to treat her? Is there a prescription we can give her? And if there is, what is it? And what are some other recommendations? So pause, think to yourself what prescription you could give her. And hopefully you all came up with Tamiflu, because oseltamivir is an effective treatment for influenza. Some other recommendations, what would those be? Pause and think. Okay, the recommendations that you would give her would be to inform her employer, since she's working with the public quite a bit, that she's got a positive flu case. Inform her household contacts, and of course you have to inform the state that you've had a positive flu swab. Alright, so now I want you to think to yourself, what if her rapid flu test was negative? What are some alternatives? Pause. And back. Alternatives would be human metapneumovirus, parainfluenza. Okay, so the alternatives again would be, sorry, I just had to pause that recording for a second. Human metapneumovirus, parainfluenza virus. Again, we talked about some other possibilities, such as the enterovirus D68.
My phone cracked.
I know my phone cracked. Sorry, I've got one of my boys in here. And we also spoke about measles and mumps as causing that clinical presentation. However, she's an adult, she's been fully vaccinated, and she does not also have concurrent signs of measles and mumps, so you probably would eliminate those.
Can I go to the bathroom?
Okay. So now I'm about to make a sacrilegious health statement. You ready? The question I have for you is, if the rapid flu test was negative and you've considered all these alternatives, does it actually matter which one is actually causing her clinical signs? Probably not. And the reason why it wouldn't really matter is that you're going to treat her exactly the same way. It's not going to change your clinical behavior. you're probably going to give her ibuprofen and to control her fever and make her comfortable. And if she's having severe respiratory distress, signs of respiratory distress, you're going to give her probably a nebulizer treatment to make it easier for her to breathe, or oxygen if she needs it. Other than that, knowing whether she has paraflu or human metapneumovirus, it's not going to change your clinical behavior whatsoever. All right. So that is vignette number 1. Now let's go to vignette number 2. And this is a case of mystery illness. And now we're in Key West, Florida. I'm going to change my pen color here. We're in Key West, Florida. We're in a primary care physician's office, and it's December 5th. And our patient here is a 12-year-old female. She's got complete vaccination series. Her medical history is pretty unremarkable. She's had a couple broken bones. And recently she's traveled to New York City. She visited the Bronx Zoo. So her presentation is she goes to, oopsies. She goes to her primary care physician. Sorry about that. I forgot to change that. And she's had a 4-day history of moderately high fever, so a bit higher than standard for a virus. She's had chills. She hasn't been eating. She's been feeling nauseous, but no vomiting. She's got malaise. She's just tired. She feels gross. For the past 3 hours, she's had a history of skin discoloration. So she's got some reddening spots. She's got some yellowing of her skin, and she's quite agitated.
What does agitated mean?
Agitated means she's acting erratic and angry. And oh wow, this is still recording. I just realized that. Sorry guys. Well, now you know how I would describe what agitated means to a 7-year-old. Anyways, okay. So your clinical plan. What are some possible etiological agents, bearing in mind her clinical signs and where she is geographically? And then finally, what are some of the critical circumstantial factors? Pause and think to yourself. Okay, hopefully you're back. For etiological possibilities, there's one really big one, and the tip-off here is the yellowing of her skin, the jaundice. That is very typical in this instance of yellow fever. That's very typical in her instance of yellow fever. And this is quite plausible because she lives in the Florida Keys, the very tip of the Florida Keys. That is a place where you find these guys, Aedes mosquitoes. There haven't been local transmission of yellow fever in the Keys for quite some time. I think the last cases were in the 30s or 40s, but it is entirely plausible that you can have local transmission of yellow fever in that part of the world. And you never know when it may start reappearing again. So the critical circumstantial factors here is geography. It's where she lives, and incidentally, what also lives there. A couple of you might have noticed she had recent travel history to New York, but that's not that's not a place where you'd find yellow fever. That's perfectly true. Just because your patient has a recent travel history does not mean that it plays into the clinical picture. It might, but it might not. So it's something that you always have to consider, but it isn't a guarantee that it's actually that important. All right. So that being said, let's go to our last slide. Laboratory testing that you would want to do for this would include yellow fever virus ELISA and PCR. So you can detect the RNA of yellow fever in blood from patients who are infected. In addition to that, you can detect antibodies in their blood, and you would do that using this technique right here. PCR is a technique that'll help you detect viral RNA. You can also, if you wish, do viral isolation studies, meaning you send a vial of her blood to the lab and to a clinical lab, and they'll try to actually grow out yellow fever virus. All right, so that's that. Hopefully you guys found that helpful, and good luck studying, and I will see you tomorrow.